Hello, and welcome to the Management of Orthopox Viruses. This is a presentation on behalf of the Mountain Plains Regional Disaster Health Response System. My name is Dr. Rehaan Shaffie. I'm a hospitalist at Denver Health and Hospital Authority and a member of the Highly Infectious Pathogens team. These are the disclosures for the coming presentation, and I have no conflicts of interest to discuss beforehand. So the agenda for the coming presentation involves a clinical overview on the recognition and treatment of orthopox viruses. In practice, there are two main clinically relevant scenarios, which involve either epidemic outbreaks such as monkeypox or bioterrorism attacks such as smallpox. Today's presentation will be a focus on smallpox in the setting of a bioterrorism attack. To briefly outline the coming presentation, because it is relevant to the clinical presentation, diagnosis, and transmission, we'll briefly discuss a history of smallpox, but primarily we'll spend most of our time on the transmission, clinical presentation, and diagnosis of smallpox, followed at the end by briefly discussing treatment and then containment as well. So briefly, these orthopox viruses are a diverse phylogeny of viruses, including variola, which is smallpox, monkeypox, and vaccinia, which is the basis for the smallpox vaccine. It was eradicated in the US in 1949, and the last naturally occurring case worldwide was in Somalia in 1977. It is the only infectious pathogen to be declared eradicated in history. This is directly relevant when we move on to discuss the transmission of smallpox, especially in the setting of a bioterrorism attack. So primarily it is spread via respiratory droplets and secondarily through body fluids. In 1972, routine vaccinations in the US were halted. After September 11th, 2001, some people were vaccinated. Those were primarily members of the military. However, because vaccine immunity is not lifelong, whether in 1972 or 2001, there's an unknown level of naturally occurring vaccination status. There are only two locations remaining in the world that study smallpox, the CDC and the Russian State Center for Research on Virology. Both of these locations are regulated by the WHO. As for why smallpox might be chosen in the setting of a bioterrorism attack, as previously noted, it has a respiratory or aerosolized spread. It has next to no naturally occurring immunity. It has a high mortality rate at about 30%. There would be a delay in diagnosis, given the last naturally occurring case was in the late 70s. And primarily efforts would focus on vaccination. We will discuss some treatment options at the end of this presentation, but we'll note the limitations with regard to how those are studied and how those might be implemented. So to move forward to the clinical presentation of smallpox, there's an incubation period of 10 to 14 days, followed by a pre-eruptive phase involving 2 to 4 days of a high fever, headache, backache, vomiting, abdominal pain, and malaise. As we move forward in the presentation to discussing the diagnosis of smallpox and the differential diagnosis, the high fever and this febrile prodrome will become an important part of understanding the disease presentation. This pre-eruptive phase is followed by an eruptive phase. The rash starts on the mucous membranes, palate, and forearms, and then exhibits centrifugal spread throughout the rest of the trunk and extremities. The rash of smallpox is notable for its slow evolution, starting as a macular rash, progressing to papular, and finally ending up as pustular. We'll look at pictures in the coming slides. It does also involve the palms and soles, and globally the patient appears toxic or moribund. So these next couple of slides demonstrate the rash. This first one illustrates the progression from the maculopapular stage, illustrated on the left at about day 3, to day 5, when it becomes more pustular, and day 7, when it becomes more widespread and the pustules are more evident. This slide illustrates the rash spreading throughout the entire body, in the lower extremities on the left, and the trunk on the right. The complications of this initial clinical presentation have to do with either the systemic inflammatory response prompted by a severe viral illness or compromised skin integrity. Those complications include secondary bacterial infections, corneal ulceration, keratitis, arthritis, osteomyelitis, pneumonia, orchitis, and encephalitis. The outcomes of any or a multitude of these are what lead to the high mortality rate of smallpox, and that includes coagulopathy, hypotension, and subsequent multi-organ failure. So to diagnose smallpox, the most important, as I previously noted, clinical characteristic for diagnosis is the febrile prodrome. So of the 3 major criteria for diagnoses, the first is a febrile prodrome, including at least one of the following: prostration, headache, backache, chills, or gastrointestinal distress. All of those, it should be noted, are fairly general viral infection presentations. The second major criteria involves the classic smallpox lesions, and the third involves these lesions in the same stage of development. So even though it does spread centrifugally from the mucous membranes down through the trunk and extremities, if there are macules on the face, there will be macules on the shins, and same as it progresses through the stages of papules and pustules. The minor criteria involve much of what we've spoken about before, including the centrifugal distribution, the first lesions appearing on the oral mucosa, palate, and forearms, 1 to 2 days between each evolution of the lesion, lesions on the palms and soles, and an overall toxic appearance. This flow sheet from the CDC illustrates how you can best evaluate patients for smallpox using these major and minor criteria. The far right and red column involves classifying a patient as high risk. This means that they meet the 3 major criteria: the febrile prodrome, the classic lesions, and lesions in the same stage of development. The central or yellow flowchart classifies patients as moderate risk of smallpox. This includes the febrile prodrome and either one other major smallpox criterion or more than 4 minor criteria. And then finally on the left is the green or low risk category. Notably, these patients either do not have the febrile prodrome, again illustrating how foundational that is for the clinical presentation and diagnosis, or they do have that prodrome, but less than 4 minor criteria. The differential diagnosis for smallpox includes a varicella or chickenpox infection. This tends to predominantly be on the trunk and extremities, is marked by lesions in different stages of development, and notably presents without the febrile prodrome. Monkeypox is marked by cervical and inguinal lymphadenopathy, and those patients typically are not quite as sick as those infected with smallpox. Disseminated zoster begins in a dermatomal distribution and typically becomes disseminated in patients that are already immunocompromised. And then drug eruptions have a very generalized distribution and tend to be more maculopapular in presentation. So we'll briefly spend some time on the treatment of smallpox. There are three main options: tecovirimat, brincidofovir, and cidofovir, with the dosing available on this slide or to be dictated by the CDC in needed cases. All three of these available medications have been approved by the FDA under the FDA's animal rule, which states a drug can be approved based on high-quality animal studies for life-threatening diseases when human studies are not ethical or feasible. The data that we do have regarding these medications tend to be from case reports. Those case reports involve patients that are also typically treated with vaccinia immune globulin. Again, because there is not a robust data background for these medications, guidance on the exact dosing, administration, and use of concomitant medications, such as the vaccinia immune globulin, would come under the direction of the CDC in needed cases. This means that, in addition to treatment, many of the efforts at caring for smallpox patients involves efforts toward containment. These include airborne and contact precautions, vaccination for exposed individuals, and immediate vaccination for patients themselves, which may reduce disease severity. Vaccines and medications are both available through the National Strategic Stockpile. It should also be noted that the U.S. National Strategic Stockpile has enough doses of the smallpox vaccine to vaccinate everyone in the U.S. Thank you very much for your time and attention. Here's my contact information, and you can find further information on the associated one-pager for this presentation.